life course immunization, protecting health across all ages. Professor Sipho.
Good afternoon and thank you for coming. I just need the... So I've been asked to speak to you about life course vaccination, and I hope by the end of my talk you'll be able to at least appreciate the value of vaccination. So if you can have my slides up, please. So I'd like you to imagine a world where your life course doesn't depend on, or the duration of your life does not depend on vaccine preventable infections. And I'm saying to you today that vaccines offer us that shield to protect us, not as children, but also as adults, so that we can live our lives fully fulfilled and not suffer from the consequences of infections. So this session or my talk has been sponsored by Sanofi, but there's a disclaimer here that they had no role in the creation of this talk. I am quite a bit of a vaccine advocate and have done a lot of advocacy relating to vaccinations for adults, and these are just my conflicts of interest. So I will try to encourage you by the end of this to really consider vaccination as a strategy, not only as a good strategy for children, but also for adults. And I certainly think adults' vaccination is something that is poorly done. So just to begin with, I think everyone appreciates the value of vaccination. Certainly, over the last 50 years, vaccines, especially the childhood program of vaccination, has prevented almost 150 million deaths globally. And that has ultimately led to people living longer. And if you look at the graph there in the middle, you can see that for most of our time on this earth as human beings, we've been living not beyond 30 years of age, but certainly in the last 200-300 years, because of vaccination, we've been able to extend our longevity. Yes, access to clean water is part of that, but I think largely I would say the contribution to longevity has been the use of vaccination in our childhood programs. Now, we want to use vaccines to do that for adults as well, because we think that certainly the use of vaccines for adults will probably lead to healthier aging, and I'll show you in subsequent slides. Just for context, if you look at China, they have about 8 antigens in their childhood program, and you look at the cost of that vaccination program. This is an article that came out earlier this year. You can see that the cost there for that program runs into billions, but what they get in returns is almost more than 19 times of that, and you're talking about 2 trillion rand. So this is what vaccination programs do for countries and economies. There's certainly evidence to show that if children don't die in the early period on Earth, they certainly live longer and contribute economically to a country. The other values of vaccination really include things like preventing some of these drug-resistant infections that are around, certainly prevent hospitalization, certainly preventing deaths, and certainly have these benefits that are beyond just the action of just vaccinating and protecting the individual. And so clearly, vaccination isn't just for children. We've got to move beyond that, and it's got to be looked at as life course. So also not to look at it just for particular age groups, whether it's just for maternal use or the elderly. It is throughout one's life. And I'll just give you a schema later on of some of those vaccines that may be useful for different phases of one's life. However, having said that, there are vaccines available which are recommended for adults, but there has been poor use of them, either the poor recognition of just the morbidity and mortality that adults suffer from vaccine-preventable infections, and also probably from our side as clinicians and healthcare workers, not advocating for the use of vaccines. And of course, there are the issues of economics, who pays for the vaccine, and how then do you encourage people to do that if they're paying out of pocket, and these issues of education in terms of vaccination as a good benefit, both for the individual and sometimes for one's community. Just to frame things, globally there is a framework that is encouraging life course vaccination. One, as the globe has realized that the number of people that are going to be above 60 is going to double. Currently we sit around about 1 billion people who are above 60, and the estimates are that by 2050 that number will grow certainly to above 2 billion people. And that, if we don't prevent some of these vaccine-preventable infections, is going to cause a lot of economic hardship in communities because of the managing the burden of disease and infection. And what we are wanting is for people to start aging in a healthy manner. And certainly vaccination is a strategy that will help us achieve healthy aging. And certainly there are many declarations and documents through WHO and other groups looking at these decades of how to achieve healthy aging. WHO as usual likes to have these agendas which are either 10 years, 20 years and have an end date. So if you look at 2030, certainly is a date in which there should be a strive to achieve healthy aging. There are frameworks in which to do that, and essentially the frameworks just for using vaccine as a strategy is to keep people healthy and functional throughout their life, and certainly not suffering from vaccine-preventable infections. If you look at our continent, if you're born in 2023, there's a life expectancy, and I'm just showing you here in Africa, we've got a very young population, but with time, the age distribution is going to change, and certainly the estimates are that by, certainly in this country, I think 2050, you're probably having closer to 20% of our population who are above 60 years of age. Currently, it's sitting at around about 8%. Now, if you look at these projected growths or shifts in our population pyramids, you're going to get more older people. One of the things we have to contend with in the continent is this issue of obesity. And our obesity rates in Africa look like they're going to triple, far greater than many other areas in the world. The estimates are that by 2050, 2 out of every 3 adults on the continent is going to be obese. And that is going to put health challenges for our continent. And here I just highlight the infectious disease risk that comes with obesity. But there are other cardiovascular diseases that obesity is going to come with. So if you just look at the leading causes of death globally in 2024, you can see that vaccine-preventable respiratory infections features there. So certainly these infections are vaccine-preventable, and certainly the people who are at high risk, yes, young children less than 5, but also the elderly and those who are greater than 60 years of old are at greater risk, but also those who are immunocompromised as well. Now, this is just a schema which I was alluding to previously, that this is what life course vaccination would potentially look like. And you can see that vaccine as a strategy can be used before birth, where you vaccinate pregnant mothers to prevent infections in children, especially in the early childhood phase where they can't be vaccinated for various reasons. But as you go through the different stages of life, there are going to be important vaccines that you need. And these are not necessarily always going to be the same. I'm going to just highlight some of the a few that we would need in this country, and certainly ones I think you should be considering given the burden of disease in South Africa and our population. I'm going to start with respiratory infections. We're in the middle of the flu season. This is just some of the viruses that are circulating, and you can see that in our flu season, influenza certainly is a common circulating virus, but we've also got RSV, and certainly SARS-CoV-2 hasn't really gone away, and it's there. There's no seasonality to it, and you can see continuous feature. All of these do have vaccines available for us to use. So influenza certainly in this country causes a lot of morbidity for the elderly and certainly young children, but certainly the elderly and certainly those who are immunocompromised. It goes through pandemics and epidemics geographically, and certainly is one in which vaccines are available and are underutilized. And if you just look at the burden of disease, people living with HIV in South Africa are the highest risk. About 30% of them succumb to influenza, and we probably have about 12,000 people dying every year just from influenza. But besides that, you've got the elderly as well, and also children less than 5 and pregnant women, who are the people most vulnerable to influenza. So influenza vaccination certainly is key for these groups in this country. If you just look at this graph, this was just looking at what vaccines are available in South Africa for the elderly. You can see that influenza and pneumococcus feature here as sort of vaccines that are recommended in most of the guidelines by most societies. When you compare that to other parts of the world, you'll see that, for example, the zoster vaccine doesn't feature much in our guidelines, but it's a vaccine that should be recommended for those who are elderly. And I'll also touch on RSV, which we currently don't have as well, where the elderly are a group of people who are high risk for this infection. I just put this up for SARS-CoV-2 because it is around, hasn't gone away. It's not only a respiratory infection. You're familiar with the other extrapulmonary manifestations of this infection, and certainly we are seeing people either hospitalized or coming with some form of SARS-CoV-2 infection, and we really need to be aware that they are high-risk groups and suggest this vaccine. I understand that the availability of the vaccine in this country is still a challenge, but we are advocating to make that a possibility for those who really need this vaccine. We haven't gotten to a point where there's this universal SARS vaccine. We certainly don't even have the newer vaccine formulations with the newer antigens, but certainly getting even the old version of the vaccine is something that's still useful for our populations. Just to remember also the sequelae of SARS-CoV-2, this is just to remind you that there are long-term complications for this infection. Hence, I'm highlighting as something that you should be vaccinating people for, because it is a vaccine-preventable infection. And this long COVID is an issue that some people are at high risk of getting. So there's been recommendations, certainly from the WHO, about who should be getting vaccinated for SARS-CoV-2 and what vaccine we should be using. If you've got access to the newer vaccines, yes, use it. But if you've still got the older versions of the vaccines, they're still worth the use because they still do protect one from SARS-CoV-2. And this is just a schema for you if you want it summarized about who you should be vaccinating. Generally, the guideline is those who are above 65 and older should be vaccinated, and any high-risk individuals should be considered for vaccination. Other age groups, I think it's a conversation about the risk for vaccinating and not vaccinating. Pneumococcal infection is another big infection. Globally, it actually kills more people now than, say, HIV does. And certainly, the elderly are at high risk, but there are other high-risk group individuals. The disease may present as a simple pneumonia or invasive disease with either meningitis or a bacteremia, which you're familiar with. And really, the issue here is just that if we just look at the population that's going to be 60 and above. Globally, that is rising. Many countries now have population curves that are skewed towards the elderly. We still have a young population, but as our population grows, our population demographic is shifting. And we still do have, even in the young population, people who are at risk of invasive pneumococcal infection. You'll be familiar that there are many serotypes of pneumococcal infection. The vaccines that are available cover most serotypes, but not all serotypes. And really, the issue of pneumococcal infection is that there is also the risk of multi-drug resistance, that the vaccine, if given, is a helpful tool to preventing multi-drug resistant infection. One of the things about the vaccine is that for pneumococcal infection, it is very good at preventing some of these forms of invasive pneumococcal infection, especially bacteriemic episodes, and this is data from the USA just showing that. So very effective vaccine and one that should be used for high-risk populations. It is being used certainly as part of the EPI program for children, but it's also indicated for adults, and there are key groups for adults who are at risk of infection. Now, this is just a graph just to show you that if you're asthmatic or you have heart disease or diabetes, if you get pneumococcal infection, this is the effect on worsening that particular condition. And certainly, people with some of these comorbidities who get pneumococcal infection are at risk of their condition, that underlying medical condition getting worse. And their risk of death is high. These are just some of the numbers for you just to digest about the populations across the world who are suffering from these. And I'm showing this to you just because in our country, the number of diabetics with the obesity rate is going to go up. We already have people living with HIV, which is about 8 million. All of those people should be vaccinated for pneumococcal, against pneumococcal infection, for example. So what's the guideline? I've been part of a group that developed guidelines for the use of vaccines for pneumococcal infection or preventing pneumococcal infection in our country. And what we advocate or give guidance to is that we should be using the conjugate vaccine. And the conjugate vaccine we have is PCV13. And that covers 13 serotypes. And you should use that as the first vaccine you give. And then, depending on the risk, follow that up with the polysaccharide vaccine, which covers 23 other serotypes. The reason for starting with the conjugate vaccine has to do with the neurological basis for generating a good immune response, and that's why we suggest starting with the conjugate vaccine. And then to get broader serotype protection, you give the conjugate vaccine later on. And in the guideline, we highlight how to give it. I'm not going to go through this individually, but please have a look at that guideline, and we give a suggestion of how to vaccinate according to the risk groups and what you give first and the duration between vaccination. So for very high risk groups, the standard is that you give a conjugate vaccine first, and then 8 weeks later you would give the polysaccharide vaccine. And in sort of low risk individuals, you can give a conjugate vaccine first and then wait a year before you give the polysaccharide vaccine. So that's just some of the standard guidance we've generated here, and then also give guidance as to when you would need to revaccinate. And this is just what happens when people have been vaccinated before, and what you should do. There's guidance in that document as to how you deal with those scenarios as well. I want to cover RSV because I think it's an important infection, often not understood in terms of its epidemiology in adults. So certainly the pediatricians recognize this as an infection, which I think if you listen to pediatricians often say they hate the RSV season because the hospitals get full and elective procedures, for example, get cancelled because there's children who have been admitted with RSV. RSV certainly is there in the elderly, and certainly is a contributor to morbidity and mortality, certainly in those 60 years and older. And again, a vaccine preventable infection. There's a number of vaccines in the pipeline for RSV. Certainly, since understanding this, how to make a vaccine for RSV has been a challenge for many years. But since our understanding of the pre-fusion protein, that has helped us understand how to make a vaccine so that we can target the antigens that are important for generating responses to RSV infection. And there are a number of attempts and certainly strategies about RSV, from vaccines to also monoclonal antibodies, which the pediatricians do use and potentially use as well, but also to just vaccines which are now becoming available for the adults. And in the next slide, this just shows you the different phases of some of the studies that are available for RSV vaccination and therapeutics. Importantly, just recently, we've got a maternal vaccine for RSV, which is indicated for pregnant women, which would protect young babies before they can get vaccinated. It's also indicated for those who are 60 years and above. So it's available, and one which I would start encouraging you to use in those who are 60 years and above, and certainly with comorbidities because they're at high risk of RSV infection. This is just to highlight to you that there are vaccines that you should use in pregnancy. So I've mentioned RSV, but there are others like influenza, which I've mentioned, but also tetanus, diphtheria, and pertussis are important vaccines to use during this period, mainly used to protect young infants who are highly vulnerable to these infections and are not eligible for vaccination by the time they are born. So that's why maternal vaccination is a strategy to use to protect young babies. So I'm almost done. Really highlighting that live course vaccination is an important strategy, certainly to prevent vaccine-preventable diseases. This is a schema I propose that we should be doing, and the red just highlights the ones I think you should be considering for use in adults. And certainly I've highlighted key ones in adolescents. Remember, adolescence is also a period where you may want to do catch-up vaccination. And then there are going to be vaccines you want to use for adults, especially adults with comorbid conditions and those who are immunocompromised. Now, many adults who get these wonderful biologics for autoimmune diseases, but that also puts them at risk of some of these vaccine-preventable infections. And certainly the elderly, I think, there are key vaccines that they need so that they can function optimally and age well and not age and being frail and probably succumbing to some of these infections. So in conclusion, hopefully I've highlighted to you the importance of adult vaccination and live course vaccination. I think it's important to begin to do that in your practices so that people maintain their function, maintain a healthy life, and certainly for the elderly are able to age very well. And really, vaccines are cost effective and a positive contributor to society. And with that, I'd like to thank you very much.
Okay, the slogan is what? Vaccinate, don't vacillate. But here, we're moving beyond the infants, beyond the expanded program of immunization, EPAC. What you're going to call this an extended or extraordinary program? We're going to vaccinate everybody, right? Okay. Thank you very much, Sipho, for that good overview and informing us that if we want to, what age? Healthy. You have to be vaccinated. So this, the only thing Sanofi is going to sell us the vaccine at a reduced price, hopefully. That's where the big problem comes in for the private sector. Anyway, okay, the floor is open for questions for Sipho. Yes, the pulmonologist there, Professor Akhtar.
Before he asks his question, how many of you are actually vaccinating adults in the room? Okay.
Sipho, I just want to ask you about the herpes zoster vaccine. I mean, if you've had chickenpox is it worth it in the elderly? And then it's mainly a morbidity issue in patients, I think. So is it really worthwhile? And secondly, the RSV vaccine, is it available now for us, and should we be using it in the elderly?
Yes, so I'll take the second question. RSV vaccine is available and should be used in the elderly. I think certainly there's a benefit of using the vaccine in that age group. I think one of the things, especially with adults, we probably underestimate the burden of disease. So when you look at some of the data is almost suggesting that the burden of diseases, especially during RSV season, is probably in the elderly is probably similar to influenza, and its effects on the elderly is similar to influenza. So adults who get influenza can, the mortality risk is high. So certainly those who have comorbidities, I think, should be considering it. So I think if you were to ask me as a strategy for the elderly, I'd say if you're a fit 60-year-old with no comorbidities, you probably can wait until you're 70 before getting an RSV vaccine, for example. But if you are a 60-year-old with diabetes, hypertension, and ischemic heart disease, then I think you really need to have your RSV vaccine, because I think if you get RSV or even influenza, the risk of those conditions getting worse is high. Your first question was related to zoster vaccination, right? So if you've had chickenpox, the risk of zoster as you age increases, and certainly as you approach 60 and beyond, that risk increases. Yes, the zoster reactivation is a morbidity issue, but the problem with the zoster is that you may recover, but the pain is is a big issue, and the vaccine seems to be good at helping that morbidity. So it's suggested that as a strategy that 65 is the age in which you probably should think about your zoster. There's a debate, and it also depends on which vaccine. So there's a live vaccine, and then there's a recombinant vaccine. The live vaccine probably works well if you're 65. However, its longevity isn't as great as the recombinant vaccine. So if you had a choice, the recombinant vaccine is better because it probably will give you a duration of 10 years compared to the live vaccine. Now, if you are 75 and older, the live vaccine is not a good idea because its ability to stimulate an immune response that is protective is much poorer compared to the recombinant vaccine. I hope that answers your question.
Thanks.
Yes, so the question was about the availability of the zoster vaccine. The truth is, yes. Currently, what is available is the live vaccine. The company which makes the recombinant, I think it's GSK, have promised to register the product in the country. I think one of the challenges is going to have it available at a reasonable price. What I've heard is that the recombinant vaccine is a 2-shot vaccine and it looks at retailing at about 7,000 or 8,000 a shot.
Dr. Khan,
human papilloma virus and survival and the link to cervical problem, would you advise vaccinating all youngish women, all young women?
Yes, so the human papilloma virus vaccine, yes, is available. Currently, the way the strategy works in the country is that it's a school program, and it's given to girls between from the age 9 to 14 is what the school program does. Yes, so all girls should get the vaccine because that is the key vaccine to prevent cervical cancer, yes. There's debate about whether that also should be offered to boys as well. Because even human papilloma virus infection is something that men can suffer from, but much later in life compared to women.
Dr. Jum?
Meningococcal disease in South Africa seems to have a prevalence primarily in the Western Cape, as far as I remember.
Meningo or pneumo?
Meningococcal.
Meningococcal.
So, what is your views on administering it in pediatrics generally in South Africa? Should we be selective? Should we do it in certain parts of the country, or should it be done across the board?
My answer is going to be a caveat. First, I'm not a pediatrician, so I can't really speak to pediatricians. But what I can tell you about the disease burden in adolescents and adults is that, yes, the disease burden is very low. Now, the vaccination strategy especially for prevention of meningococcal infection is going to be for high-risk groups. And in our country, you're quite right, there is a coastal and inland difference in the spread of infection or risk of infection. Certainly, when it comes to young adults, those going to university certainly are at high risk and should be vaccinated. We've seen, and we've done studies at our University of Cape Town, when we looked at our first year students, and we've seen that as they enter some, depending where you come from, certainly from inland, they don't come with any nasopharyngeal carriage, but within a year that changes. So there's something about living together in the dormitories or student housing that they get from other students. And secondly, we've seen some outbreaks with fatalities, I think, in our universities. The last one that comes to mind is from Potchefstroom, where they had an outbreak and I think they had some fatalities. So that university has made a standard, I think, recommendation that all students get vaccinated. So certainly, when it comes to meningococcal vaccination, adolescents or those going to university should get vaccinated. And then all other populations becomes, it's a risk. And then it's going to be if you're traveling, and then there are some travel places where you travel, you have to be vaccinated.
Just to add on from our point of view, from the seroprevalence, the meningococcal serotypes, the one in the Cape is the B, for which there isn't a vaccine. That's where the problem comes. There is a vaccine in other parts of the world. And from the other parts, we see them sporadically. Right? But the one that is of problem in northern Africa, what's called meningitis, but that's serogroup A. And so that's a different ballgame. But for any mass gatherings or living in hostels, etc., it's recommended. And there was a study where they looked at students at enrollment and 3 months down the line, and they found high prevalence carriage of the meningococci. So from that point of view, it's advisable for travel, mass gatherings, and in hostel and military dormitory settings, etc.
Okay.
So that's.
So those of you who are in the Gauteng province and this province, just remember that there are religious gatherings. So if some of your patients are indicating that they go to these yearly gatherings, it's probably a good idea to bring up the issue of meningococcal vaccination.
Hi, I just have a question regarding the vaccines in pregnancy. So, you often find patients coming to you prior to falling pregnant asking what can they do and to check them out, and we would often just check rubella, antibodies and stuff. Would you suggest that, because for the RSV you have specific time that you take, can you take prior to falling pregnant? Some of the other vaccines, should they actually do that, before falling pregnant?
The answer to that question is the reason for timing is twofold, right? One is you don't want to do too early because there may be risks, right? But the second is that the primary intention of maternal vaccination often is to is to have enough maternal antibodies so that the young neonate is protected before they can even get any vaccine. So it's about timing of ensuring that you vaccinate, mom produces enough antibodies, and those antibodies are going to certainly pass on to the child. So for many, one doesn't advocate for vaccinating prior to pregnancy because you're not going to really get those benefits. And I think for RSV, it's quite clear that there is this time window which people should try stick to.